see my slides?
We can see, Doc.
Okay. Okay, so today we'll just do a recap of the immune responses to infections, and then just mention briefly on the related immunopathology. We won't go into very much detail of specific microbes because you covered all that in your second and third year. But I just want to reiterate that you didn't leave your microbiology in third year. You know, this is the knowledge that you gained. You continue with it for the rest of your time in medical school, and even when it comes to practice, because infectious disease actually forms a big burden of disease in our setting. And probably a lot of what you'll be seeing will be the related pathology. Sometimes it will be immune pathology. So the disease presentation will basically be because of the host immune responses to the particular microbe. So that's why I just wanted us to do a recap of this. So we know we group our infectious pathogens into different groups. We have the viruses, bacteria, and the parasites and fungi. So I'll divide this lecture just into those different groups. So we'll start with the host defenses against viruses. I decided to put it first because, again, it's very relevant because we are still in a pandemic. So we know that viruses are obligate intracellular pathogens, which means they can only replicate once they infect a host. So they have to actually gain access into the intracellular compartment for them to replicate and then facilitate spread to other cells, okay? Most viral infections are usually, very benign, rarely lethal. We think about the common cold, for example. Even if they're highly cytolytic to individual cells. So there are some infections which would cause cytopathic effects. You'll see some of this in your systemic pathology lectures, especially the herpes viruses, for example, which cause changes to cells that you may be able to see macroscopically in the tissues, and even microscopically, you will be able to see changes to individual cells, what we call the viral cytopathic effects, and there are different kinds of cytopathic effects. So most, and usually with most viral infections, people recover pretty quickly because the host immune response is able to control or limit the infection. But there are some viruses that cause mortality. Most of the time, mortality will occur either when the virus jumps species, and this is what happens, especially with the influenza viruses. For example, the swine flu, or bird flu, when you get viruses like the influenza viruses from a particular species, now infecting the human host. Okay, usually there would be no prior immunity to that because we may not have been exposed before, and that's what leads to a lot of morbidity and mortality. Mortality also, can also occur when the viruses undergo a major antigenic change. Seen very well with the influenza viruses, the ones that tend to cause the seasonal flus. And then also when host immunity is compromised. This is seen very well in the setting of acquired immunodeficiency syndrome, where you have people who basically have no immunity or very low immunity, and then they succumb to or get very severe viral infections that usually don't cause severe disease in immunocompetent hosts. So this would be the opportunistic infections. So this table just summarizes the principal means by which the host achieves immunity after viral infection. The first column shows us the viral events in terms of the events that would cause infection or in the infective process. And the second column shows the obstacle, or basically the host defense mechanism. And then the last column is a time course. So we can see that mechanical and chemical barriers, which are part of the innate immune response, but they're very nonspecific, usually would prevent transmission, because for the virus to cause infection, it has to basically bypass one of these barriers, okay, For example, if it's causing gastrointestinal infection, it has to be taken in through the mouth. If it's causing a respiratory infection, it has, for example, SARS-CoV-2 causing infection in the lungs, it has to be inhaled. So those barriers would prevent transmission, and those are usually present. So unless they're breached, okay, then they would limit infection. And then the second obstacle will be the innate immune response, which includes both cells and soluble factors. So your cells would be, for example, your dendritic cells and your phagocytes. Soluble factors would be things like your cytokines and complement components, okay? So these are also present at any one time. So that's why it takes, from initial exposure, they can respond very quickly. And this would help to limit infection and replication. If that is bypassed, remember these cells of the innate immune response, especially the dendritic cells and macrophages, are the ones that link the innate immune system to the adaptive immune system. So through taking up these antigens and processing them and presenting them to T lymphocytes, usually in the lymph nodes, that is how we will activate our adaptive immune response against viruses. And this happens also pretty quickly within a day, but it takes time for proliferation of your activated T cells, which would now go on to activate other cells. For example, your CD4 T cell may produce cytokines that activate. Did someone raise their hand? Is that a question? Or was it a mistake? I think it was Sharon. Okay. So it takes time for the cells of the adaptive immune system to be activated and to proliferate. Sharon, please ask your question because you're raising your hand. Sharon Simiu. Okay, I'm not able to tell why your hand is raised. Do you have a question? Because you can unmute and ask. Otherwise, please lower your hand or I'll just probably ignore you. Okay. So I was talking about your antigen presentation and activation of your T cells. So your CD8 positive T cells can be activated directly. For the CD4 T cells, this would produce cytokines that now activate other immune cells. For example, cytokines that activate your B cells to produce antibodies that would be viral specific. And I think we remember the effector functions of antibodies. Okay, and we can see that it takes time for the adaptive immune response to come into play, probably 4 to 10 days. With SARS-CoV-2, I think people are saying it from about 7 to 14 days for a proper adaptive immune response or detectable antibody level. And we know the properties of the adaptive immune response, one of the major ones being immunological memory. So with activation of this response, we end up with long-lived memory T cells and long-lived memory plasma cells, which would be present to initiate a quicker reaction on second exposure with the same pathogen. It lasts, the length or the time, lifetime of this immune memory is variable. For most viral infections, it can last a lifetime. For example, for measles, for some, it's very short-lived, a few months, especially for the coronaviruses. When it comes specifically to SARS-CoV-2, they're still following up people after vaccination just to see how long the antibodies last. And that is what is going to determine whether or not we get booster immunizations and at what interval. There's an aspect of sterile immunity. Sterile immunity describes the presence of immune memory against specific pathogens that would completely inhibit transmission, okay? It's as opposed to herd immunity, where you still may get some episodes of transmission because there are some people who are not protected, but with sterile immunity, exposure to the pathogen gets rid of it immediately. So it doesn't cause infection, doesn't cause transmission to other hosts. However, all pathogens have mechanisms by which they want to evade the immune response so that they can survive and continue proliferating. So there are several immune evasion techniques that come into play. And this would cause persistence of the viral infection if the immune system is not able to get rid of these viruses that are escaping. And I think the viruses that tend to cause persistent or latent infections like the herpes viruses. And this would later be problematic because they can cause other pathologies to arise just because of the fact that they keep being reactivated, going back into latency. So things like your oncogenicity and so forth. This picture just summarizes the different routes of viral entry. And I think the actual innate immune mechanisms that will be present at these sites. For example, tears and eyelashes to prevent ocular infection. For gastrointestinal infections, you have saliva and some of the enzymes that are present in saliva and some of the chemicals as well, the acid in the stomach and so forth, mucus and cilia and so forth in the respiratory tract, the process of flushing out of urine in the urinary tract and things like that. And then the skin barrier in itself would prevent entry and infection through the skin. So for all pathogens, in terms of defense against infection, we always group this as innate immune defenses and adaptive immune defenses, just to ensure that we remember all the relevant details. So the purpose of the innate immune responses is to block or inhibit initial infection. If that doesn't happen, if you still do get some infection, for example, they bypass the barriers, then it's to protect other cells from infection, so to stop the propagation of that infection. And then the cellular responses would help to eliminate virus-infected cells, and even some of the soluble responses like complement. Remember, one of the major functions of complement is to cause cell lysis, okay? And the other important aspect of the innate immune cells is to activate the adaptive immune responses. So for that to occur, of course, the cells of the innate immune response, your phagocytes, dendritic cells, have to recognize that there is a foreign pathogen or antigen. So usually they recognize what we call the pathogen-associated molecular patterns, and they have several types of receptors that can do this. We call them pathogen recognition receptors, or rather pattern recognition receptors. So they recognize certain components on these microbes that are not present on normal host cells, okay? And then they become activated. So when they are activated, or basically when you just have exposure to a virus, this virus can be directly inactivated by complement, okay? Remember the alternative and mannose binding lectin pathways of complement can recognize a pathogen or can be activated by pathogen directly. So once they're activated, they can cause complement components can opsonize this virus and it's taken up. They can cause lysis of viral infected cells. There's production of cytokines and chemokines by some of these innate immune cells, which will induce an inflammatory component. You can get activation of your natural killer cells, which would probably get rid of infected cells. We also have mechanisms that will protect cells from infection. So if you already have an infected cell, this infected host cell can produce your type 1 interferons, that's interferon alpha and beta. And what these interferons do, they induce an antiviral state. So they make it difficult for the virus either to propagate by inhibiting protein synthesis of that infected cell, because remember the virus takes over the protein synthesis machinery of the cell. So that in itself would prevent viral infection, but they also cause a resistant state amongst neighboring uninfected cells. So that tends to inhibit infection of neighboring uninfected cells. These interferons can also activate T cells and natural killer cells. The other cytokines are also important in initiating an inflammatory cascade. So your interleukin-1, tumor necrosis factor alpha, and interleukin-6. The cells of the innate immune system can also destroy or inhibit virus-infected cells. Natural killer cells are very important in this aspect, and they're able to recognize virally infected cells when these cells downregulate expression of MHC. So downregulation of MHC and specifically MHC1 expression is one of the viral evasion strategies by, or rather immune evasion strategies by viruses. So when they do that, when natural killer cells come across cells that have downregulated MHC1, that become activated to destroy those cells, okay? And macrophages and neutrophils usually would ingest virions that have been opsonized by complement. For the adaptive immune responses, here we have involvement of both T and B cells. B cells would produce antibodies that can perform various functions that would be antiviral, for example, neutralization of the virus. Neutralization just means binding to, for example, the viral glycoprotein that is implicated in cell entry to prevent infection of a cell. They can perform opsonization, and you know what that means, or they can actually enable killing of these cells through antibody-dependent cellular cytotoxicity. Antibody can also activate complement, and complement would come in and perform its effector functions. Your CD4 positive T cells, usually the important function of the CD4 positive T cells is to produce cytokines that would, and chemokines that would activate other cells, okay? And your CD8 T cells, usually are cytotoxic. They kill using similar mechanisms as the natural killer cells, but this usually would be able to, remember, as the virus is replicating within a cell, you get viral proteins being produced, and these viral proteins can actually be processed as peptides and presented on the surface of the infected cell via MHC1. So in that way, it's going to be recognized by your CD8 or cytotoxic T cell, and then the T cell is activated against that particular, any cell that's bearing that particular peptide on its surface on MHC, okay? So the NK cells and CD8 probably do the same job. It's just that, so when the viruses are trying to evade recognition by T cells, they downregulate MHC1. So even if now they've evaded the CD8 positive T cells, then that downregulation of MHC1 would enable the natural killer cells to detect them and get rid of them. So this is a summary of the principles of antiviral immunity. I already alluded to the fact that many human viruses are successfully controlled by the immune system. That is why a lot of viruses don't cause severe disease, but you do have some emerging viruses which can overwhelm the immune system and cause severe morbidity and mortality. Case in point, SARS-CoV-2. I've talked about evasion strategies by some viruses that would enable them to cause persistent infection. A good example are the group of your herpes viruses. And then it's already been shown using the case study of HIV/AIDS that defects in adaptive immunity, people with defects in adaptive immunity demonstrate more severe viral infections, but there are also people with defects in innate immunity who would develop severe viral infections. For those with defects in innate immunity, most of them tend to be the primary immunodeficiency disorders, which we will discuss on another date. So I just want to reiterate that T-cell immunity is more important for control of viral infections and antibodies. And I'll just bring back the issue of HIV/AIDS. With the depletion of your CD4 T cells, you're actually not able to mount a proper cellular immune response. Even if our patient has normal numbers of B cells, is able to produce antibody, without that T cell component, you're not going to have.
Kwa nini?
Okay. So without competent T cells, antiviral immunity is not going to be complete. I'm not saying that antibodies are not important. They are important because they minimize reinfection through the presence of, the function of neutralization, okay? So usually when someone has viral specific antibodies, not all the antibodies present are neutralizing antibodies. So the important component, the functional antibody, would be the one that inhibits viral entry into its target cell. Okay, so that's the importance of neutralizing antibodies. That is what we are trying to achieve with the vaccination against COVID-19. It's also much easier to measure antibody levels than to try and evaluate, the viral specific T cells. Okay, so the antibodies are basically used as a correlate of protection. And immune memory usually would be sufficient to prevent secondary disease, although this is not seen in all viral infections. For example, the coronaviruses that cause the common cold or the rhinoviruses, usually we don't have lasting immune memory. And there are also some other viruses which don't invoke very good immune memory that would prevent secondary disease. When it comes to the evasion and persistent infection that causes chronic disease, there are several delay tactics or blunting tactics that are used by viruses to enable them to escape detection by the immune system and to continue replicating. So one is where they kill or infect antigen presenting cells. So if that happens, then you don't have proper antigen presentation, so you cannot activate your adaptive immune response. There are some viruses which prevent or delay apoptosis by cytotoxic T lymphocytes. So they prevent cytotoxicity, okay, or inhibit cytotoxicity. There's some that interfere with the process of antigen processing and presentation. So of course, just like the first example I've given, if that happens, then you don't get good activation of your cellular adaptive immune response. And those are examples of viruses that do that. There are some that destroy T cells. We've already said T cell immunity is very important to provide protection against viruses. So HIV is able to evade destruction, like complete elimination, because it destroys T cells. I've talked about downregulation of MHC on the surface of infected cells to escape killing by cytotoxic T lymphocytes, although this would enable natural killer cells to get rid of disinfected cells. Herpes viruses tend to do that. The viruses which produce mimics of cytokines, which are immunosuppressive. So we call them like immunomodulators or inhibitors of cytokines. An example is EBV, which produces a molecule that is homologous to interleukin 10. And remember, interleukin 10 is an immunosuppressive cytokine. So this homolog that is being produced by EBV will act on your activated T cells to downregulate their function. There's some that will inhibit the action of complement or maturation of dendritic cells so that you don't get proper activation of or antigen processing and presentation. There's viruses that infect immune privileged sites. Sorry for the typo. And remember, with these immune privileged sites, you hardly have any immune activity going on there. So they're actually not going to be detected by immune cells. So for example, in the nervous system, so the viruses that infect neurons like your herpes simplex and varicella zoster. And then the other aspect is antigenic hypervariability, which enables them to escape any antibodies that have been formed against them because you get new epitopes, okay? Or any viral specific T cells. This can occur during transmission from a host to a host, whether it's an animal host to a human host or human to human host. The aspects of antigenic shift and drift seen very well with influenza. Or you can even get this antigenic hypervariability occurring within hosts who are already infected, and then you end up getting viral escape mutants, seen commonly with HIV, especially among patients who are not adhering to their antiretroviral treatment. This lack of adherence enables generation of viral escape mutants, which now become even resistant to whatever antiretroviral regimen is being given if it's not being taken properly. The other aspect of immune evasion is when you have persistent infection with some viruses, there's always like a load of virus within the circulation. So persistent viremia, which just causes some sort of persistent inflammation, which with time leads to impaired T cell function. So you either get reduced cytokine production of these T cells, or they just become functionally exhausted. They can't proliferate anymore, even if they're being exposed to cytokines. And some can actually now undergo deletion. They die, okay? Just because of this persistent antigen load and persistent inflammation that is there. It's thought to occur due to what we call co-inhibitory signaling. So remember, to activate your T cell, you need your first signal to be the antigen being presented to the T cell via MHC, and then you need a second signal, the ones we are calling the costimulatory signal, okay? Like your B7 and 6 molecules interacting with the CD28 molecule on your T cell. However, part of the immune regulation process is to dampen this costimulatory signal when you have a trigger that probably is not sufficient to cause a good immune response. So sometimes with persistent viremia and this sustained antigen exposure, instead of getting co-stimulation, you get co-inhibition. So the molecule important is what we call the program death 1 or PD1, interacting with its ligand, the PDL1. So instead of your T cells being activated, they become inhibited. This has actually been taken advantage of to be used as one of the immunotherapeutic mechanisms for certain cancers, where you're giving either a monoclonal antibody against the inhibitory receptors, because cancers also tend to do this so that they evade immune response. You get upregulation of this inhibitory receptors. So the molecules that can be given either to block the receptor or to block its ligand, okay? So that you get activation of your immune cells. People are also looking at the aspects of immune exhaustion also in severe SARS-CoV-2 infection. So it's not only seen in HIV, HCV, and HBV. I've seen people looking at it also in COVID-19. So what are the outcomes of viral infection? So if you're able to control the infection, of course, we develop immunity, but sometimes you develop immune pathology, and these outcomes vary in different persons. I think we've seen this with SARS-CoV-2. Some people get infected, they're asymptomatic. Some get infected, they have mild symptoms. Some get infected, they have severe symptoms. Then they recover. Some get infected, they have severe symptoms, and then they die. So there's a lot of variability in the outcomes of different viral infections, and there are multiple factors that are involved. One is genetic susceptibility. So genetic susceptibility could be anything to do with genes that code for certain components of the immune system, genes that code for MHC, genes that code for viral entry receptors. For example, if we talk about SARS-CoV-2, there may be variabilities or polymorphisms with the ACE2 receptor amongst different people that would either increase the risk or decrease the risk of infection. The other factors that are important that would affect the outcome are the age of the host, the dose of infection, route of infection, variability in induction of an anti-inflammatory process, presence of concurrent infections, other things that would make someone at higher risk of getting sicker, and past exposure to cross-reactive antigens. So there's a multiplicity of effects that come into play, and this will impact the response that a certain host has to a particular viral infection. So the immune responses, especially the inflammatory responses and the cytotoxic responses against the infected cells, usually would result in tissue damage, okay? So, I mean, of course, if you're killing an infected cell, it's a host cell. That's some sort of tissue damage. Usually, when this is controlled and happens over a short period of time, it's going to be immunoprotective because you end up getting rid of all the virus. All the virus. But sometimes you tend to get prolonged inflammatory responses or cytotoxic responses, which now end up causing more tissue damage than what is expected. And that is what would be considered immune pathology. So this tends to occur with persistent viruses, but it can also occur with other viruses that are not persistent when you get overactivation of the inflammatory mechanisms, just like we have seen in cytokine storm. And also when you have persistent infection, because you have chronic inflammation going on, chronic tissue damage, this can also lead to development of autoreactivity through several mechanisms. We'll go into details of autoimmunity later, but autoreactivity can be seen, for example, with some of the hepatitis viruses. And sometimes you can also develop an oncogenic response, okay? Seen with KSHV, with EBV, with hepatitis B, and so forth. So this is just a list of examples of lesions resulting from immunopathology. This list is not exhaustive. You'll come across many more. You'll see patients who present with this kind of immune pathology. Okay, so now I'll move to your intracellular bacteria. So intracellular bacteria, here, what you must know is Mycobacterium tuberculosis, okay? That is a must know, like you're not going to finish medical school without knowing TB. So that would be the prototype when we're talking about intracellular bacteria. So these often cause persistent or latent infection in the face of an ongoing immune response. So there's some sort of balance. Sometimes the immune response is not able to get rid of the pathogen completely, but it controls it so that it cannot spread, okay? So you do get persistence of the bacteria inside your mononuclear phagocytes or your macrophages, and low to absent bacterial mediated toxicity to the host. And we'll see how what makes patients sick when they are infected with Mycobacterium tuberculosis. Most of the time, especially if it's a HIV negative individual, it's the immune response. It's not really the bacteria that causes pathology. It's the immune response that is responsible for causing pathology. So protection against intracellular bacteria usually involves both your innate and immune cells. It requires activation of these infected phagocytes by cytokines, and these cytokines come from the T cells. So, the phagocytes present these antigens, the bacterial antigens to T cells. The T cells produce cytokines that activate the phagocytes, and then now you expect the phagocytes to be able to get rid of the pathogen, okay? That is basically described or well demonstrated by that reaction that we call the cellular hypersensitivity or type 4 hypersensitivity. I'll allude to that signaling pathway a lot. It's my favorite signaling pathway. And that's another thing that you must know. I'm likely to examine on it, or any aspect to do with Mycobacterium tuberculosis. So the cytokines, which are the most important, described or well demonstrated by that reaction that we call the cellular hypersensitivity or type 4 hypersensitivity. I'll allude to that signaling pathway a lot. It's my favorite signaling pathway. And that's another thing that you must know. I'm likely to examine on it, or any aspect to do with Mycobacterium tuberculosis. So the cytokines, which are the most important in mediating protection, are interferon gamma and tumor necrosis factor alpha, which are produced by the antigen-specific T cells. So these activate your phagocytes so that they're able to kill bacteria through several mechanisms. So induction of your reactive oxygen and reactive nitrogen intermediates, delivery of lysosomal hydrolytic enzymes to the bacteria containing phagosome, autophagy of the infected cells, of formation and maintenance of granulomas, okay? So as I mentioned, there's actually a balance of your persistence of bacteria and, like a minimal immune response to just try and contain those intracellular bacteria. And that's why the infections tend to be persistent. Like these are chronic infections, okay? However, it's important to note that even if you don't have, like these infections are persistent, we're not able to get rid of them completely, one has to have competent T cells so that they can mediate this type of response, okay? So they're very important in actually maintaining or protecting or providing defense against intracellular bacteria. And this is another thing that we learned from HIV/AIDS, where there was actually a very dramatic increase in the incidence of TB in patients who have AIDS. TB is endemic in our region, in sub-Saharan Africa. So it's always been there. But when AIDS came into the scene, there was a very large increase in the number of people who presented with tuberculosis. And that just shows that without competent T cells, then we cannot provide good protection. So the other thing I want to mention is on granulomas. I know you know a lot about granulomas. I don't know whether you talk about this. I think you do in third year, because this is one of the early topics on granulomatous inflammation. Probably in systemic pathology, you come to see different organs that, TB can affect different organs and you can form granulomas. But you can also get granulomas being induced by other pathogens and even by non-pathogenic material, okay? So when we talk about the balance of protective responses and host pathology, this is well illustrated with the granulomas. So there are certain events that take place that could either be protective or pathogenic. Okay, so when you have your interferon gamma and tumor necrosis factor alpha being produced, this activates your macrophage. I've told you what the activated macrophages do to help in bacterial death, induction of your oxygen metabolites, release of your lysosomal enzymes. So those are protective responses, okay? You can also get your CD8 T cells causing, cellular killing, killing of infected cells. So that would be a protective response. However, when these cells are lysed and you have viable bacteria within this macrophages, they can be released, and then you get dissemination of the bacteria. So that would be a pathogenic response, okay? Also, sometimes with these granulomas, you get development of central necrosis, because I'm sure you've seen how all your immune cells come in and they try and cough off this infected area. And then sometimes you even get fibrosis, so that whole infected area is walled off. So of course, with that fibrosis, you don't get very good circulation in the center of the granulomas, and that's what leads to necrosis. So this would result in death of the bacteria, which would be protective, but it also results in death of the host cells within the center of that granuloma. And of course, that is pathogenic. The fibrotic encapsulation would be a protective response. Sometimes you get overexuberant necrosis and fibrosis, which can even present as a space-occupying lesion. For example, if you have granulomas forming within the brain, so that would be something that is pathogenic. Okay, and then finally, if you get liquefaction of this necrotic area, what we call caseous necrosis, this can lead to, remember, the bacteria within the center of this granuloma are usually viable. So they continue replicating. You can get cavity formation and transmission of your bacteria because they get released from the cavities into the circulation. So this would be a pathogenic response. And now one would be contagious. Okay. So for example, if they cavitate into the bronchi and someone is coughing, then, as they cough, they're releasing mycobacteria into the environment. So this was just to show you the difference between a solid granuloma and one that has undergone caseating necrosis. And I'm sure you've seen the cells in your rotations in anatomic pathology and how we are able to tell microscopically that this is granuloma. Okay, so how do this intracellular bacteria evade the immune effector mechanisms? So one would be, if they're taken up, remember most of these, yes, they're intracellular, most of these tend to infect the cells of the mononuclear phagocyte system. But these cells are phagocytes, okay? When they take up pathogens or antigens through phagocytosis, there are several mechanisms that come into play that now lead to acidification of that phagosome, fusion of that phagosome with the lysosome, and then you get killing of what has been taken up. So all these pathogens do sometimes, they're not taken up through phagocytosis into the cell. They use another cellular receptor to gain entry into the cell. So that doesn't activate the cell, okay? For it to be active to produce or to acidify and start releasing the reactive oxygen intermediates. So an example is when they're taken up through complement receptors, okay? So these cells have complement receptors, the ones that they use to bind to cells or pathogens that have been opsonized by C3b, for example. So if they get into the cell through that, they're sneaking into the cell. So this prevents production of your reactive oxygen and nitrogen intermediates. The other thing that they can do is to inhibit maturation of the phagosome. So that's the process of acidification, so that you can now induce the reactive intermediate. So if they inhibit the maturation of the phagosome, then they basically prevent killing by both your enzymes and the oxygen and nitrogen intermediates. They can also secrete scavengers of the reactive oxygen intermediates, which would actually inactivate these metabolites, okay, like the lipoarabinomannan that's found on the cell wall of Mycobacterium tuberculosis. Some of them, once they've gained entry into the cell and they're in a phagosome, they escape from the phagosome into the cytoplasm. So when they're just free living in the cytoplasm, then you cannot have any fusion with the lysosome that would enable killing, okay? I've talked about inhibition of phagosome maturation. Yeah, I think I'll stop there for that. Let me just see how we're doing on time. Yeah, I'll try and finish the bacteria and then we can do the other pathogens later because of time. So host defenses against extracellular bacteria. Just like for the other pathogens, you have your innate and adaptive responses. The innate ones include nonspecific ones, and then things like your cells and your soluble molecules. So one important aspect that that helps to provide defense against extracellular bacteria is just presence of the microbiome, okay? Or the microbiota, or what you call the normal flora, okay? So this helps to balance your commensals versus the pathogens and to prevent colonization by these extracellular bacteria. The first step that will be necessary for extracellular bacteria to cause infection is that they have to adhere to the epithelium at the site where they're causing infection. Before now, they're able to colonize and start replicating, okay? So the commensals basically try to keep them in check. And when the microbiota is, or the normal microbiota is altered through different ways or disrupted, for example, by antibiotics, then now you're actually allowing for, or you're creating space for your pathogenic organisms to expand, okay? For example, in the gastrointestinal tract, we have the usual microbiota, for example, E. coli, and so forth. So once someone is put on oral antibiotics, especially when it's not necessary, okay? This would get rid of some of these commensals and would actually allow for any pathogenic bacteria to now adhere and colonize. So I think you've talked about this when you looked at Clostridium difficile in microbiology and also Salmonella typhimurium. The other thing that can happen is that you now alter the microbiome by selecting antibiotic resistant members of the microbiome. We see this a lot, especially in clinical microbiology in the practice of pathology. The other thing is that even changes in human physiology can cause a change in the microbiome. So things like smoking would alter the respiratory tract microbiome. I know a long time ago, people used to say like the respiratory tract, especially the lower respiratory tract, is sterile, but it's been found that it's actually not completely sterile. There are normal microbiota within that tract. Exposure of the skin to elevated temperatures and humidity, chronic stress, and host immune suppression. And actually, studies on the microbiome have actually become very widespread. People are looking at issues to do with the microbiome and implications of even non-infectious disease, things like obesity and cancer and so many other things. So it's actually an expanding field in medicine. And then the other non-specific defenses would include things like antimicrobial peptides and proteins. I think we talked about a lot of this in second year. So your defensins, cathelicidins, lysozyme, and so forth in different tissues. You can look at this table later in detail. Then the other important aspect that I never like students to forget is that for one to develop a host immune response that would end up activating the adaptive immune system is that your innate immune cells have to recognize that there is a pathogen, okay? So recognition by innate immune cells is the same, whether it's a virus or bacteria. It involves the use of pattern recognition receptors, recognizing the pathogen-associated molecular patterns. So this table is just given an example of the PRRs, like toll-like receptors, the node receptors, some of the complement proteins, although the C1q would be a PRR, but this would only be activated by an immune complex, not the pathogen on its own. Things like proteins like CRP. I know we use CRP a lot in monitoring patients, for inflammatory events, but actually what its actual function in the body, it's actually a PRR, okay? And then these are examples of the pathogen-associated molecular patterns. So they're just components of the cell wall or cell membranes of these bacteria that are absent on normal host cells. So once there's recognition, then you get activation of different immune components or cells. You can get activation of complement, and you know what complement does. Your dendritic cells would be involved in antigen presentation. Your macrophages would also be involved in antigen presentation, but they can also cause killing of this extracellular bacteria by phagocytosis and induction of either the oxygen or oxygen-independent killing. Polymorphonuclear cells, your neutrophils, usually would cause phagocytosis and killing just like the macrophages. When we activate the adaptive immune cells, these are the T cells and the B cells. So we know the B cells would produce antibodies. We know what the antibodies do. For the T cells, I just want to mention that the T helper 17 cells have been shown to be very important. Remember yesterday I said that this is the newest subset of T helper 17, of T helper cells identified. The CD4 cells usually have three components. So the T helper 1 that are involved in pro-inflammatory responses, T helper 2, which are mainly involved in antibody-mediated responses, and then the T helper 17, which usually produce interleukin-17 that is highly chemoattractant for neutrophils. So this would, you can see like there's an interplay between the adaptive and the innate immune cells. So you get your innate immune cells activating your lymphocytes, then you get differentiation of or proliferation of your T helper 17 cells that produce cytokines, which are involved in attracting neutrophils to the site, okay? This is a summary of the host defenses to your extracellular bacteria. So you have your barriers, your antibacterial proteins, mucus, for example, in the respiratory tract, like in the nose, the cilia, normal microbiota, adherence blocking molecules. For example, urine and the fact that it's flushed out would block adherence and colonization within the urinary tract. And then specific defenses, your innate immune cells, complement, immunoglobulins, phagocytosis, and so forth, and your T cells. So these are just some of the factors that would enable attachment by your bacteria, and they are considered immune evasion strategies because some of these are like pathogenicity factors for these microorganisms, because they're actually, it's what enables it to be adherent and then colonize. So it's basically able to bypass any host defense mechanisms at that point, okay? So things like your pili and fimbriae, or you have adhesins produced by some of these bacteria that actually facilitate this process. And once they attach, then this is what would enable close adherence. Sometimes they can even invade epithelial cells. For example, when you have E. coli invading epithelial cells within the urinary tract, then as the urine is being flushed out, you know, they're tightly adherent, so they don't get flushed out. So other immune evasion mechanisms, there are very many. These are just a few examples. You know, changing or phase variation of the adhesins, or changes in like the lipopolysaccharides, so that, you know, the actual surface antigens are hidden from the immune system. Negative regulation or inhibition of complement, proteolytic degradation of IgA within the mucosal surfaces, so that it's not going to be functional. Elaboration of molecules that would actually reduce the efficacy of your enzymes and reactive oxygen intermediates within the phagocytes. For example, catalase production by Staph aureus. And that is why we'll come to see that patients who have functional phagocyte abnormalities tend to be very susceptible to infections by Staphylococcus aureus. Presence of a polysaccharide, or, you know, molecules that help them resist phagocytosis, like the capsules, which are usually polysaccharide capsules. So without the presence of opsonins like complement and antibody, then this would be an antiphagocytic mechanism, or things like pili, which are also antiphagocytic. Some bacteria can secrete leukocidins. Cidin means death, so this would cause cell death or lyse your polymorphonucleosides, or they will secrete enzymes that would inhibit chemotaxis. So for example, your C5a peptidase. Remember, C5a is the complement component that is very chemoattractant and can actually even cause, could be an anaphylactoxin. So this peptidase actually inactivates it. The other thing that can occur, you can get antigenic mimicry in a way that, okay, we know antigenic mimicry can lead to autoantibody formation, and that would cause immune pathology from that infection, but it can also dampen the immune response, okay? So that, because these molecules will be recognized as self, so you don't get, if there's proper tolerance, you don't get an immune response against the pathogen. If there's another factor that leads to breakdown in tolerance, then that is when you get autoimmune pathology developing, okay? So I think I just want to highlight that just the presence of one cause of autoimmunity is not enough to cause pathology or autoimmune disease. You need an interplay of factors, and we'll discuss that later. Some of these bacteria form biofilms, so they're able to hide within those biofilms, and this shields them from the host defense mechanisms, especially if you have like invasive procedures done, like presence of a catheter, and then they form a biofilm over that catheter, and they just continue proliferating there. This patient is always, like if it's a urinary catheter, always having UTI, but you can't really get rid of that organism or identify because it's hiding. There are certain factors, just like for the viral infections, that would predispose some people either to local or systemic invasion, or basically severe infections or recurrent infections by these extracellular pathogens. I'm finishing in a few. Okay, so can you please mute your mic so that I finish? We started late. So this would be polymorphisms in some of the innate immune mechanisms. We'll discuss that under immunodeficiency disorders, absence of opsonizing antibodies. So for example, patients who have, my God, that's very irritating. Who are those irritating students with their mics on? Okay, absence of antibodies that would opsonize this pathogen. So patients who have like antibody deficiencies, whether they're losing them secondarily or they have a primary immunodeficiency, would be very susceptible to infections invasive infections by extracellular pathogens, deficiencies in the complement pathway. And I've already mentioned either absence or reduction in neutrophil numbers or even function, okay? In terms of deleterious host responses, which would now cause immunopathology. So this can be brought about just by the inflammatory process, especially depending on what organ is involved. So for example, if it's in the brain, in a patient with pyogenic meningitis, this would either lead to, remember the features of inflammation. So you do get swelling, so you get brain edema, okay? And you can get infarcts. So this can end up causing even more pathology than just the presence of the pathogen itself and secondary complications. If there's molecular mimicry, you can develop autoimmunity. And then the other deleterious response is sepsis, which is of course provoked by the inflammation, but this time it's dysregulated and it becomes overwhelming. Sepsis doesn't occur only with extracellular bacteria. We also see it with other pathogens, for example, viruses like SARS-CoV-2, okay? We've seen that patients who develop severe COVID-19 actually develop sepsis. It's defined as basically a life-threatening organ dysfunction caused by dysregulated host response to infections. And this can also lead to septic shock, where now one develops hypotension, multiple organ failure, and it can actually be or cause mortality. Because of this dysregulated immune response, this also predisposes these patients to secondary infections, especially if they're in hospital. They tend to also develop or get nosocomial infections. This would be with less virulent organisms. And that is just because of the immune dysregulation that occurs. Usually, I keep saying that with every immune response in the body, there's always an aspect of immune regulation. There always has to be a balance so that you don't get overwhelming responses. So sometimes just the fact that as the body is trying to regulate the immune response and you get an anti-inflammatory response, this can actually cause some sort of immune paralysis, which is what would predispose these patients to secondary infections, especially if they have any breaching of their physical barriers. They can get infected through IV lines or bladder catheters. Okay, so because of time, I think I'm going to stop there. Perhaps we can look at the defenses and pathology regarding fungal infections, helminths, and protozoa at a later date. Can you remind me? Any questions?